It's a pleasure to be here. And this is a more important topic now as we are entering the zone of doing more and more complex PCIs. So we're going to have more and more sick patients. And we have to find an algorithm or a pathway to deal with such patients because most of these patients will be very high risk for surgery. So high risk PCI patients with complex CAD who would need mechanical circulatory support. One, who is high risk complex PAD or cardiogenic shock. Why do you need it? Because you need hemodynamic stability to enable complete revascularization. And why? Because it should reduce procedural complications, improve outcomes, and you should be able to send the patient home because, as you know, high-risk PCIs and cardiogenic shocks are associated with high mortality. There are different MCS support devices available. We have been using IABP for a long time. Not to ridicule it, it still is a great tool in a country like ours. It's just that many a times we use it late, which is a major problem. Then came this percutaneous MCS, that's the Impella series. They came with 2.5 and 3.5, that's the CP. And then came the TandemHeart, which never came into our country. And of course, there is Impella 5.5, but that needs to be surgically implanted, or you can do percutaneous subclavian implant. But that's generally used for cardiogenic shock patients or a bridge to surgery or a bridge to transplant. And of course, our grand old VA-ECMO still is there. Although the data, the danger shock trial showed more harm with VA-ECMO than benefit, but in our country, it still has some role. So how do we enhance these outcomes and quality of life for such patients? So whenever a patient with coronary artery disease comes to you, we first decide medical versus revascularization. Then we decide PCI versus CABG. Then we have conventional PCI or protected PCI. And when do we use protected PCI? When do we use conventional PCI? So patients which are indicated for protected PCI will be multiple, will be a binary thing between three. You have to take into account the patient comorbidities, the complexity of the coronary artery disease, and the hemodynamic compromise. So amalgamation of these three will give you which patients you should select for protected PCI and will there be benefit once you use protected PCI. So the Indian clinical expert consensus which has recently come in, which was led by Rajiv Tayal, so he came up with a document with all the Indian physicians to create a score. So when you have a score, you first assess high risk for PCI. It should be a multidisciplinary approach. It cannot be only the treating physician or the treating cardiologist. You need your anesthetist, you need your cardiac surgeon, you need everybody on board with you. And then you create algorithm. Clinically, you look at the hemodynamics and the patient characteristics, and the score is 1 or 2. Then you look at the coronary anatomy and the procedural characteristic. What devices will you be needing? So if your score is less than 3, then generally you go for conventional PCI. Anywhere between 3 to 5, you can consider the support. And more than 5, almost always, you should use support. So I'm going to present a case for you and then go into a little bit of data. This was a 92-year-old lady, diabetic, a doctor's grandmother. She had episodes of angina class 3 since 1 month, troponin elevated. She was mobile. She used to work at home. She used to do everything. Limitations were daily activity due to chest pain. EF was 30%, distal IVS apex anterior hypokinetic, and creatinine was well maintained. So we clearly had a chat with her, do you want to do something at this age? Because that's an age where people would say, I would rather sit at home. But the granddaughter and the patient herself are very clear, either I live properly or I don't want to live. Do what you need to do. So this is an angiogram, calcified ostial LAD, also ostial circumflex lesion. So we gave her the option of doing a protected PCI with an Impella. She said, go ahead, because I thought this is not a great case to just put an IABP and do it. Of course, we can always do these cases with IABP. We have done cases like this without IABP. But once you have therapy available, when you have the resources, we should offer the best to our patients. Her syntax score, as you can see, was more than 35. Age was huge. The complex PCI was offered to her, and they accepted it. Then the problem started with the left femoral artery puncture. The Impella sheath just wouldn't go across. And then we realized that there was a huge calcified spur at the bifurcation of this. And then our TAVI experience helped. We took a huge, long 14 French cook sheath and we pushed the Impella through that. Finally, we got the Impella in. Of course, there was some effort because the sheath also wouldn't go beyond this. And that time we didn't have IVL. Those time IVLs were not available, peripheral IVL. So we had a choice was going to balloon it or to put an IVL. But we finally managed to cross the sheath across the stenosis and push the Impella up there. Impella in position, the cardiac power output was more than 1. We were happy with this. Then we put a 7 French XB3 guide catheter. We did a rotational atherectomy. The LAD looked better after the rotational atherectomy. Then we did the rotational atherectomy to the LCX ostium.